Hello everyone, welcome to my first ever video on my YouTube channel. I hope you all are doing well. I'm a medical intern. Currently with the COVID pandemic, I think many of the medical students find it difficult to get access to their patients, and also there are so many restrictions even in hospital settings. So I thought of maybe discussing a couple of questions online, which I hope will help you stay motivated and continue your studying from home. So in my series of videos, what I'm going to be doing is initially I'll be giving you a question, and you can take your own time and try to attempt it. And at the end of it, it'll be followed by a couple of slides which will be discussing the topics around the question, which I think will help you to answer more confidently. And at the same time, this knowledge, you can use it even in the future to apply these principles in similar kind of questions. So over time, we can collect all these different questions and make a question pool, a question bank, which will be accessible to anybody online. So this question you see, I've taken it from USMLE website, and it's a question for USMLE Part 2 CK. You can take a look at it and try to attempt it yourself. I'll just quickly give a summary of it. 32-year-old man who has difficulty focusing on tasks for 2 months. He has lots of energy and often is distracted, and he does not complete assigned tasks. He has also developed greater efficiency in his shop, and he has got a newfound energy, and he only needs about 4 hours of sleep at night. However, there's no past history of psychiatric illness. There is a history of drinking alcohol excessively and using methamphetamine and cocaine during his 20s, but at the moment there is no alcohol intoxication. And on examination, he describes his mood as good. However, his speech is rapid in rate, but there are no delusions or hallucinations. So what do you think is the answer for this? Alright, so let's analyze each and every answer stem in detail and come to a conclusion at the end of it. So first is antisocial personality disorder. So the personality, there are different personality types, and what is a normal personality? It's defined as an individual set of emotional, behavioral traits which are generally stable and predictable. But when it's abnormal, what happens is the individual becomes very rigid and maladaptive, and it ultimately leads to social and occupational dysfunction. So one of the commonly encountered abnormal personality traits is antisocial personality type, and these are the commonly seen traits I've displayed here. So they'll be violating others' rights, and also they're not considerate about the social norms or how others feel, and no consideration for country's laws. And also they lack remorse for their activities. Maybe they've had a history of conduct disorder as children, and generally we diagnose antisocial personality disorder after the age of 18 years. So looking at these characteristics, if we can attribute this to somebody that you know, an individual you know, it'll be easy for us to remember it even in the future. So I thought of taking a prototype from history, Ted Bundy, so it's given as an example for antisocial personality. The next is borderline personality, and this what happens is they generally have very unstable mood and also unstable relationships. By this what I mean is they are very quick to run into relationships and also break off relationships. And what's the reason for this? They generally try to classify individuals into groups, very extreme groups. For example, they'll be thinking individuals are either 100% they're very good or they're 100% very bad. And so if they see even like minor, not so tolerable traits in an individual, they'll classify it as 100% evil and they'll dislike them for it. At the same time, they're very impulsive and very judgmental sometimes. Therefore, they jump into conclusions without giving it much thought. So associated with this, they can also have self-harm, deliberate self-harm, suicidal ideations, and also can have drug abuse and all that. So another example from history is Marilyn Monroe. So even though she was not diagnosed with a borderline personality, they say that she exhibits a lot of traits which are now found in borderline personality type. So next is bipolar affective disorder. So this is also another mood disorder where there are manic and depressive episodes happening recurrently. So to remember the characteristics of it, there's a mnemonic here. Dig fast. D is for distractibility, I for indiscretion, G grandiosity, flight of ideas, activity will be increased, and there will be sleep deficit, and they will be very talkative. So generally, what I mean by this is an individual with bipolar affective disorder can present to the hospital in a manic episode. So when they're in a manic episode, they'll be very distractible. They're very talkative and they can't focus on one thing for a long time. And they will be having flight of ideas, which means they'll be jumping from one idea to another very rapidly. And they have very big plans. They can overspend sometimes. Sexually, they're disinhibited. So like that kind of nature they develop. And sometimes also they can have delusions and hallucinations, which are mood congruent. And what do I mean by that? Um, so they generally have a very elated mood, and agreeing with this mood, they have grandiose delusions. For example, they might think they are the god, that they can do anything, they have a lot of powers, and they can do anything. So that's the typical presentation of a manic episode. Sometimes also these patients can present in hypomanic episodes. And what I mean by that is something which is less severe than manic episodes. So for example, hypomanic patients could be a little talkative and a little overactive, which is definitely abnormal for the individual, but they might not be very sexually explicit or disinhibited like that, like in a manic episode. So manic episodes are very severe in nature and they also need hospital admission. And hypomania might not need hospital admission. And generally, by definition, manic symptoms will be lasting for more than 1 week, and hypomanic symptoms generally has a short duration of time for about 4 days. And like I discussed earlier, manic episodes can present with psychotic features. They are hallucinations and delusions, but hypomanic episodes typically do not have psychotic features. Right. So, bipolar affective disorder is further classified into type 1, type 2 in ICD-10 and DSM classification. So, bipolar type 1, how do we categorize, how do we identify bipolar type 1? Is if a patient presents with a manic episode, then that patient has bipolar type 1. And in bipolar type 2, these patients do not have manic episodes, they've never had manic episodes, but they've had hypomanic episodes. And also necessarily, they should have had one or more depressive episodes as well. So both of it together, hypomanic and depressive episodes, we call it as bipolar type 2. But bipolar type 1 doesn't necessarily need a depressive episode. Even one manic episode, we classify it as bipolar type 1. Next is cyclothymic disorder, which is a chronically lasting symptoms for about more than 2 years sometimes. They have cyclically appearing hypomanic and depressive symptoms, which are very long lasting. And these features sometimes you cannot really classify it under, for example, the depressive symptoms, you cannot really classify it under major depressive episode in ICD-10, for example, but they experience depressive symptoms, intermittent hypomanic symptoms, which are chronically lasting, and it has poor prognosis. So let's look at treatment of it. and there's always an acute management because generally manic episodes are considered as psychiatric emergencies because there is a threat to themselves. They can attempt suicide, and also there is a threat to people around them because they can be aggressive sometimes. So it's a psychiatric emergency. And depending on the severity of the episode, we can combine pharmacological agents such as mood stabilizers and antipsychotics like olanzapine and clozapine. And also we have to talk to the patient and try to verbally de-escalate and calm down the patient. And if still the patient is not responding, ultimately we might have to give ECT. So once the patient is out of the acute stage, we also have to think about the long-term management. And generally, the first-line treatment in bipolar disorder is lithium. Lithium is a pretty good drug because it's very effective in manic episodes, and it's a very good mood stabilizer, and it's also proven to reduce suicidal risk. So next line drugs are lamotrigine, carbamazepine, and valproic acid. And also we have to follow up the patient in a psychiatric clinic, and the ultimate goal is to prevent relapses because more relapses they get, poorer the prognosis is. So yeah, so discussing about lithium, we have to always know the side effects of lithium. So the common side effects we see are diarrhea, nausea, thirst, polyuria, tremors, weight gain, and in the long term, they can even have hypothyroidism. So during their follow-ups, they have to be followed up with thyroid profile. At the same time, it's important to remember the contraindications for lithium. Pregnancy is one contraindication, and also if the patient has poor renal functions, we discontinue lithium because lithium has a narrow therapeutic index. So therefore, and also at the same time, lithium is excreted by our kidney. So if kidney function is affected, lithium will accumulate in bloodstream and cause lithium toxicity. And because it has a narrow therapeutic index, it can easily cause toxicity. So what are the features of lithium toxicity? Generally, these patients will present with ataxia, dysarthria, and even seizures sometimes, and cause tremors. All right, so that's about lithium, and I hope you know some side effects of the next second line drugs, and I'll just mention a couple of important points. For example, valproic acid, we don't use it in pregnancy because it can cause neural tube defects and it's also teratogenic, and also it's contraindicated in hepatic disease. Right, so we have covered a lot of ground around the subject, and now let's go back to the question and see if we can dissect it more, better than before. All right, because now we know a lot of things around the topic, isn't it? Okay, so coming back to the question, as a 32-year-old male presenting with difficulty focusing on tasks for 2 months, and he also has associated increased energy, distractibility, and he does not complete assigned tasks. Also, he has plans to develop great efficiency in his shop, and there is some newfound energy, and he does not need a lot of sleep. He only has 4 hours of sleep at night. So it very much looks like a manic episode, isn't it? Well, so there are some other clues also, mainly to exclude other stems in the SBR. He has performed well at school because one stem given here is attention deficiency hyperactivity disorder. So generally, this we diagnose when the child is very small, and when they are children, they have hyperactivity and poor attention. However, as they grow up, hyperactivity reduces a little bit, but their poor attention persists. So generally, as adults, they don't typically present with hyperactivity, like in this case. So we can exclude that option. So also it says he has had a history of alcohol abuse, but at the moment he is not intoxicated. It's given in the history. So from that, that's also important because we have to always exclude alcohol, possible alcohol intoxication and illicit drug use, because sometimes these patients also can present like manic episode. So it's important to exclude it. So next we have already discussed thoroughly antisocial personality and borderline personality. So now you know what it is, and it's definitely not matching this picture, and it definitely is not a major depressive disorder. So voila, we have dissected it very well. All right, so that brings us to the end of our question, and I hope you learned a lot from this. So hoping to see you in my next coming up videos. Thank you for listening. Cheers then.